Prakash Patel. I'm a cardiac anesthesiologist, actually, at the University of Pennsylvania. I'll start by first saying thank you to the Omics group and the organizers for inviting me here today to talk to you a little about the role of perioperative steroids in cardiothoracic anesthesia and surgery. It's not an area that I get to focus my research on, but it's related to a lot of my research, which is coagulation in cardiac surgery. I'll start with my one disclosure is that I'm primarily a clinician, so 80% of my time is in the cardiac operating room. So my talk today is not going to go into a lot of the mechanisms of action that a lot of our speakers have shown us today, or any details of steroid pathways. We have a lot of experts that can do that. Instead, I'm going to be focusing mostly on patient clinical outcomes with regard to steroids in cardiac surgery. So besides that one disclosure, I have no other disclosures or conflicts. Brief outline, I'm going to go over just a little background on the inflammatory response after cardiac surgery, which we know is well established. And then we'll focus on the role of steroids and what they can do to impact that inflammatory response and what effect they have on inflammatory mediators. Despite that effect on inflammatory mediators, there's still an ongoing controversy that exists in medicine right now with the routine use of steroids in cardiac surgery. We don't routinely use them. And we'll go over some of the controversy as far as what the studies have shown. And then after that, we'll talk about the two large trials, two very recent large randomized controlled trials that have just come out, the DEX trial and the SEERS trial. And then finally conclude with a couple of thoughts on some future studies and what we should be looking for in further investigations, given that these two large trials still haven't really answered the ongoing debate on whether steroids should become routine in cardiac surgery. So first, just a little background on the systemic inflammatory response during cardiac surgery. We know that the inflammatory response occurs as a response to tissue injury, and depending on the severity of your injury, one can mount a systemic response leading to a systemic inflammatory response syndrome, or SEERS. And this is especially common during surgery, where you're certainly going to have tissue injury, more so in cardiac surgery, where there's a well-known inflammatory response. And in cardiac surgery, one of the reasons why there's a little higher response is that patients are going to go on cardiopulmonary bypass. So here, blood's going to be removed from the body, oxygenated, filtered, goes through plastic tubing, which is a non-endothelial surface, artificial surface, gets cooled, gets reheated, and then returns back to the body. And so it's going through this heart-lung machine. We're adding a lot of causes for perioperative inflammatory response. So some of those are going to be the shear forces that's driving the blood through the bypass circuit. So these roller pumps that are churning the blood to move it forward. The blood's getting cooled, so it's going to get hyperthermic and then get reheated before coming back to the body. There's contact activation of plasma protein systems. It said blood's being exposed to an artificial non-endothelial surface, which it doesn't like. In addition, you have ischemia reperfusion injury. There's release of endotoxins. And then, as I mentioned earlier, aside from the bypass circuit, you're going to have operative trauma just from the surgery itself and tissue injury. So lots of pathways involved in this, and there's, again, I won't go into detail on them, but there's activation of the coagulation cascade, the fibrinolytic system, complement system, leukocytes, endothelial cells, and platelet activation. All of this is going to ultimately involve the release and generation and release of like leukotrienes and other cytokines that are inflammatory mediators. The same thing, but just in a chart format here. On the top left, just on the stimuli that we mentioned leading to activation of the mediators. You can see the complement system, the cytokines, free radicals. There's a transcription factor involved, and then ultimately outcomes. So you see lipid peroxidation, leukocyte extravasation, cell death, and edema. And this is all great, but what does that mean for the impact on the patient? Those outcomes that we just showed on that prior slide are all occurring at the cellular level, but we know that the inflammatory response, and specifically those inflammatory mediators, are going to contribute to some of the patient outcomes that we see. So we have inflammatory reaction contributing to myocardial dysfunction, respiratory failure, renal impairment, neurologic dysfunction, coagulation disorders, mostly just coagulopathy. There's a lot of bleeding after cardiac surgery, impaired liver function. Occasionally, in some patients, you're going to see multi-organ failure. And so what can we do to attenuate that SEERS response, that inflammatory response? Well, one option is you could avoid cardiopulmonary bypass altogether. And so if you're getting a CABG or a bypass surgery, you can do it off pump depending on where your lesions are. That's not always feasible. So if you're going to get a mitral valve replacement or mitral valve repair, most surgeons are going to have to put you on pump to do that. And then just as a side note, I mentioned that you still can get an inflammatory response from the surgery alone. Remember we said that the operative trauma and tissue injury alone is going to cause an inflammatory response, but you can get a little bit less if you're taking away the bypass. Another option is to use biocompatible cardiopulmonary bypass circuits, for example, heparin-bonded circuits. These have been shown to work well, except, I mean, they're never going to truly mimic an endothelial surface, so you still get an inflammatory response. There's also the option to add to the bypass circuit filters, so you can remove activated neutrophils and monocytes with these leukodepletion filters, and they come with a high cost, but they have been shown to be effective, more so in pediatric population than the adult population, but certainly an option. There's also the option of pharmacologic agents, complement inhibitors that haven't really made it into the operating room yet, and aprotein, which is actually an anti-fibrinolytic drug, a very potent one, that also carried a lot of anti-inflammatory properties. It was taken off the market before I even started my practice, so I never got to use it, but from what I've heard from my senior colleagues, it was like the greatest thing ever. It was removed from the market for other reasons, came back in limited use in Europe and Canada, still not available here in the United States, but it did work well for inflammation, and although it was also very costly. The other option that we have is, obviously, while we're here, so steroids. So steroids can, we know, specifically glucocorticoids, can have a good response in trying to attenuate this inflammatory response. And so now we'll shift our focus to just what the role of steroids are in cardiac surgery. Again, a little background on why steroids. This dates back to the 1960s. It was observed that corticosteroids can improve hemodynamics in patients who have either shock or sepsis. And then it was later noted that the Sears response that occurs after cardiopulmonary bypass is similar to that of sepsis. So the obvious question then is, why not use steroids for cardiac surgery to try to also minimize that inflammatory response? And some of the early studies show that methylprednisolone could improve your hemodynamics after bypass. And this continued. There was a lot of earlier studies, 1970s to 1990s, using mostly methylprednisolone, but in very, very high doses, so a gram or 2 grams, or even as high as 30 milligrams per kilogram. And then some later studies started going down to using just moderate doses of steroids, as well as incorporating a couple other glucocorticoids as well. So dexamethasone and hydrocortisone started getting involved. So what were the effects that we were seeing when we give steroids to patients undergoing cardiac surgery bypass? Lots of studies here, but just a quick summary. There was a decrease in the pro-inflammatory mediators, so you saw a decrease in your interleukin 1, 6, 8, tumor necrosis factors, leukotrienes, and toxins. Increase in your anti-inflammatory markers, the ones we want, like IL-4 and IL-10. And there was also an attenuation of complement and leukocyte activation. This is all obviously just observation, so what we needed was now clinical trials to actually show that. So some of the early studies, here's one particular one that looked at dexamethasone versus placebo. It was a placebo-controlled double-blind trial, and I'm going to summarize a few studies real quickly, but in here, the dexamethasone group compared to the placebo group had lower levels of TNF, leukotriene, B4, tissue plasminogen activator activity. There's another two that looked at methylprednisolone, one using very high doses again, 30 milligrams per kilogram, showing that there was a decrease in the pro-inflammatory interleukin 8 serum concentrations. And then another study showing that the same drug, methylprednisolone, but at a much more modest dose compared to 30 mg per kg, still had the same kind of reaction. You could still get a decrease in your inflammation with decreases in interleukin 6, 8, and tumor necrosis factor after bypass. And one more just to show hydrocortisone involved. This is a study that was also a prospective randomized trial, placebo-controlled, looking at stress dose hydrocortisone that showed hydrocortisone compared to placebo prevented an increase in the IL-6, IL-10 ratio, so preventing the increase in the pro to anti-inflammatory response. So what does all that mean? We have all these biomarkers that are changing, but what does that mean for clinical outcomes? We mentioned earlier that the steroids, similar to their effect in sepsis, can have a role in improving hemodynamic parameters after cardiac surgery. So some studies here showing methylprednisolone, just 250 milligrams versus placebo, led to patients having higher mean arterial pressures, higher systemic vascular resistance, meaning less vasodilation after surgery. And of course, if you're going to have higher mean arterial pressures and less vasodilation, it also meant that patients were having a decreased amount of time that they were requiring catecholamine support, so a decreased amount of vasopressors and inotropes after surgery. That's great, so except the fact that hemodynamics alone are not really a meaningful clinical outcome, because then someone would argue, so what, that they were on epinephrine a little bit longer than the other patient, what does that mean for the outcome? And so that leads to the question, what is the effect on patient outcome if steroids are to be administered prophylactically to all patients in the perioperative period if they're going to undergo cardiac surgery? And we look at some effects besides hemodynamics. So there's lots of studies out there, and I'm going to summarize again a few. The early trial, before we talk about those two larger trials. One prospective randomized trial, only 91 patients involved, had an intervention group and a control group, where the control group didn't actually receive any placebo or anything, just straight control. They had a very complex hydrocortisone dosing regimen. They gave 100 milligrams at the induction of anesthesia, followed by 10 milligrams per hour for 24 hours, 5 milligrams per hour for the next 24 hours, and then divided dose of 60 and 30 for the last 2 days. And what they found was that the intervention group, the steroid group, had shorter postoperative ventilation times, shorter catecholamine requirement times, shorter ICU length of stay, and a shorter hospital length of stay, all reaching statistical significance there. Now, because they didn't actually use a placebo in that, the same group of authors then followed up with a prospective randomized trial, again, only a very small sample size of only 36 patients using the same hydrocortisone dosing, and they found, again, a repeating couple of those findings, shorter catecholamine treatment, shorter ICU length of stay, but more interestingly, something that piqued a lot of interest was that they found a decreased incidence of postoperative atrial fibrillation in patients who received hydrocortisone compared to placebo, and there was a pretty significant difference, 26 versus only 50, as high as 59%. This led to a renewed interest in, we need to use steroids, because postoperative atrial fibrillation is a big, big problem for us after cardiac surgery. The incidence varies significantly, 30 to 50% of patients, some reports as high as 65% of patients going into AFib after surgery. It becomes a very costly postoperative complication because of extended time in the ICU, having to deal with this arrhythmia, also having to deal with should they go on anticoagulation, and if so, trying to get them to therapeutic anticoagulation levels. Therefore, any agent to decrease incidence of AFib postoperatively is a desirable drug, so they had to investigate it some more. That last study, like I said, only had 36 patients in it, so this is a RCT that was done with 241 patients where they looked at hydrocortisone versus placebo, and they confirmed the findings from earlier. Patients who received hydrocortisone had a lower incidence of AFib, 30% compared to 48% of the placebo group, again reaching statistical significance. To follow up with this, there's been lots of meta-analyses. This particular one got the ends a lot higher by getting over 1,000 patients here. It included dexamethasone, methylprednisolone, and hydrocortisone. So for the study purpose and analysis purpose, they just converted everything into hydrocortisone equivalents. And they found, again, what we had seen. The corticosteroids were associated with a decreased risk of postoperative AFib. And when they limited their analysis to just looking at moderate range doses of steroids, the finding became even more significant. You can see the p-value dropped there significantly. Now, I can keep going on and on about all these early trials of what they show in the literature, but quickly summarize steroid use in bypass patients. Multiple studies confirm this, result in decreased atrial fibrillation, decreased postoperative bleeding, decreased ICU length of stay, decreased hospital length of stay, and then just to show that they're not harmful, there's no change in myocardial infarction, no change in pulmonary complications, no change in infection rates, and no change in mortality. So lots of benefits, and then also proof that they're not that bad. So why do we still not use them routinely? There's still ongoing controversy, and most institutions don't routinely give all their patients steroids when undergoing cardiac surgery. And the reason for that is there's still a lot of uncertainty about the benefit and concern for harm. As many studies showing those benefits, there's also studies out there showing that there's no benefit with the use of steroids in cardiopulmonary bypass patients. No difference in outcomes, including atrial fibrillation or time to extubation. There's also a lot of safety concerns that people bring up, and some studies that have shown that maybe there's some impaired postoperative pulmonary function if you get steroids preoperatively. Certainly these are glucocorticoids, so hyperglycemia becomes a big problem in these patients, and if you're hyperglycemic and you're also immune suppressed with the steroid, is that going to lead to impaired wound healing? And if you have impaired wound healing, then you're going to have increased risk of infection. So if you ask a lot of clinicians, they're going to be a little hesitant to give their patients steroids if this is a big concern. If a patient gets mediastinitis of their chest wound, that becomes a much, much bigger problem and much more worrisome than having somebody go into AFib postoperatively. So here's a study looking at just AFib. This time they used dexamethasone, 0.6 milligrams per kilogram versus placebo, and again another small trial, 78 patients, but they contradicting some of the findings from earlier. In this group, AFib was occurring in 30% of the steroid group versus 41% of the placebo. Despite that little difference there in the percentages there, 30-41, it still was not significant, and they're showing that steroids do not have any role in decreasing atrial fibrillation. Now, of course, I have to mention this is likely an underpowered study for detecting atrial fibrillation incidence as your primary outcome. but there have been a lot of follow-up studies, including, again, meta-analyses with much larger sample sizes that have kind of confirmed the same thing, that steroids do not decrease the incidence of atrial fibrillation. As far as impaired pulmonary function, we know that the systemic inflammatory response after bypass can cause an inflammatory response within the lungs, and that response is going to be similar to acute respiratory distress syndrome or acute lung injury. And in theory, then steroids should help improve that inflammation, but what we've actually seen is that they actually seem to worsen lung compliance, worsen the shunt fraction, your arterial to alveolar gradient, and worsening extubation times. And that's not very clear, it's almost paradoxical. So one of the possible explanations that many people have offered is that you get steroid-induced sodium retention, and that leads to a vasodilation, which leads to increased shunt fraction, as well as retaining of lung water, and ultimately pulmonary edema, leading to that impaired pulmonary function. Hyperglycemia we talked about as being a potential complication. Glucocorticoids are known to have an anti-insulin effect. With consequent hyperglycemia, they lead to enhanced hepatic gluconeogenesis and decreased peripheral glucose utilization. And this has been confirmed on a lot of studies, so I'll just give one large meta-analysis that had over 3,300 patients, again, varying ranges of steroids, all converted to hydrocortisone equivalents. But what they found was that steroid exposure significantly increases your perioperative hyperglycemia, requiring insulin therapy. You see a relative risk of 1.49 with p-value 0.01. Interestingly, despite this hyperglycemia, they did not find any difference in risk of infection. Also, some other potential risks with steroids. We know that if you're going to suppress something like the T-cell function, there's the theoretical risk that you're going to be putting your patient at risk for impaired wound healing and increased risk of infection. Certainly, these are both complications that are well known to cardiac surgery. However, there's been no direct link to steroids thus far as a cause of impaired wound healing or infection. So there's still an ongoing debate. I've shown you so far that steroids can clearly impact the postoperative cytokine levels and your inflammatory markers, but we continue to have conflicting data as far as actual clinical benefit, including mortality, and safety still remains a concern. If you're going to be administering it to all patients undergoing cardiac surgery, there's still some concerns, as we just mentioned, that are going to keep some clinicians a little hesitant to give it to every patient. And there's a lot of the current limitations of some of the evidence, as we mentioned, is coming from a lot of small studies. A lot of these, the sample size is always 100 patients or less. We're having to rely on meta-analyses to actually get real data out of this. But being underpowered, it's not really allowing us to detect any differences in mortality and morbidity. A lot of the studies also, the primary outcome that they were looking for was just postoperative cytokine levels. So they showed, okay, decrease in this inflammatory mediator, an increase in the anti-inflammatory mediators, and clinical outcomes were not always the primary goal of the studies. Also, there's a lot of varying patient risk groups. Some of the studies are looking at just low-risk groups, others looking at high-risk groups, which doesn't really reflect our clinical practice and what our patient populations typically present with. Also, one of the limitations to some of the studies that we've been looking at, they're using a lot of different agents. So we're comparing methylprednisolone, dexamethasone, hydrocortisone, and significant variation in dosing regimens. We saw that some patients getting as high as 30 milligrams per kilogram of methylprednisolone. Now some of the more recent studies have shown that we can use lower doses, low to moderate doses of steroid as well. So what's the next step? We need a large, multi-center, randomized controlled trial. And we need to figure out what is the optimal drug, if there is one optimal drug. What's the optimal dose of the steroid that should be given, and what's the ideal dosing regimen? And is there a select patient population that's going to derive the most benefit from routine steroid use? So fortunately, we have two large randomized controlled trials in cardiac surgery, both very recent investigations. The DEX trial is dexamethasone for cardiac surgery. This trial has been completed and was published in 2012. And we have those results available. The SEERS trial, not the inflammatory response this time, steroids in cardiac surgery trial just completed last year. The results are not out yet, but we have some preliminary data to look at for these. So I'll start with the DEX trial. As I mentioned, already completed, published in JAMA in 2012, intraoperative high-dose dexamethasone for cardiac surgery. Since 2012, they've had a lot of sub-analyses, so continued publications as they milk it for as many as they can with all their sub-analyses. Now, unlike all the previous studies that I mentioned, this was a multi-center, randomized trial. All the centers were in the Netherlands for patients undergoing elective cardiac surgery with cardiopulmonary bypass. And now this is much, much bigger size. We have 4,494 patients from 2006 to 2011. They chose dexamethasone, a single intraoperative dose given at the beginning of, at the induction of anesthesia, versus a placebo. And their primary outcome measure was going to be a composite of death, myocardial infarction, stroke, renal failure, respiratory failure, all within the first 30 days. And their primary outcome findings are as follows. So they found that the composite of those parameters occurred in only 7% of the dexamethasone group versus 8.5% of the placebo group. However, that did not lead to a clinical significance. We have confidence interval crossing 1 there. And so they go on to conclude that intraoperative high-dose dexamethasone does not reduce 30-day incidence of major adverse events. Well, they did a lot of secondary outcome findings as well. Some of the same as ones that we've had before here. You can see in this chart. On the far right, there's just, we'll go by the p-values, which ones actually came out to be significant, so I'll summarize those quickly. The secondary outcome findings that did lead to some significant difference from the steroid group versus the placebo group. The dexamethasone group patients were extubated sooner, meaning they got off the ventilator quicker. They had shorter intensive care unit and hospital lengths of stay. They had decreased post-op delirium, and then most interestingly here, they ended up actually having decreased post-operative infection, which was kind of opposite of what some of the concerns were earlier. We were really concerned that steroids were going to lead to increased post-operative infection, and in this large 4,000 plus patient trial, they're actually finding steroids is going to prevent infection. As far as hyperglycemia, they just confirmed what we already kind of assumed. Higher post-operative blood glucose levels, significantly higher in the dexamethasone group. Remember, they were giving a milligram per kilogram of dexamethasone too. And then along with the higher blood glucose levels, these patients required twice as much insulin as the placebo group in the first 15 hours in the intensive care unit. Interestingly also, atrial fibrillation, which was back and forth earlier, we weren't sure. In the DEX trial, they actually found that there was no protective effect of steroid here in preventing atrial fibrillation. The incidence of atrial fibrillation in the dexamethasone group was 33.1 versus 35.2 in the placebo group, so not quite reaching any significance here, but kind of confirming some of the studies earlier that doubted the prior studies. So it's just some general conclusions about the DEX trial. They conclude that dexamethasone does not reduce 30-day major adverse events. They did do a subgroup analysis that came out a little bit later, and they did actually find that there may be a benefit in a pre-specified group for steroids over placebo. And this was when they had a Euroscore over 5. So Euroscore is similar to the United States' STS score for looking at risk analysis in patients before they go into surgery. So these are patients who are considered higher risk for surgery, and they did find that dexamethasone did result in their primary outcome a significant benefit. They also conclude that dexamethasone may be effective in reducing morbidity. So, for example, delirium and respiratory failure, we saw improvements. But overall, their conclusions don't recommend that we give dexamethasone. It just says, they just kind of conclude that dexamethasone is safe without any severe adverse events. So you have complications like hyperglycemia, but there was nothing bad, really bad, that happened with the use of steroids in cardiac surgery. So with that, we'll move on to the SEERS trial, which is, like I said, just completed last year, hasn't been published yet. This is just a kind of a summary that the investigators put out last year before they actually completed it, just kind of going over the rationale and the design for their study, published in the American Heart Journal. We're still waiting the final results of it. Before I go over the SEERS trial in a little detail, I'll just go over what the difference between these two trials were. First, the SEERS trial uses methylprednisolone, which is much more commonly used here in North America. For example, for us, if we were going to give anybody steroids in the operating room, it's going to be methylprednisolone for neuroprotection usually. Versus dexamethasone in the DEX trial, which is run out of the Netherlands, seems to have much more favor over there in Europe than it does here. Also, the SEERS trial focused on just high-risk patients, so they desired to have higher event rates, so they chose only high-risk patients for their primary outcome analysis, and they're hypothesizing that there would be more benefit in this group. Also, that subgroup analysis in the DEX trial that showed that high Euroscores did have benefit with dexamethasone, that had already been released when the SEERS trial was still designing their study. So they used that to kind of change what their goal for their primary outcome would be, to make sure that they kind of went after those high-risk patients. Also, one of the other differences is that the SEERS trial required mandatory postoperative biomarkers for myocardial injury, so like CK, CK&B fractions. One of the criticisms of the next trial was postoperatively, there was a very low incidence of myocardial infarction, whether you were in the steroid group or the control group, and it was much lower than what we normally expect. It was because a lot of their centers involved in the study, the eight centers that were involved in it, didn't always check biomarkers after surgery. So even if there was a suspected myocardial infarction or myocardial injury after surgery, they didn't have any confirmation for it. So the Sears trial made that mandatory. So the details of the Sears trial, like the DEX, multi-center randomized trial in elective cardiac surgery with cardiopulmonary bypass. It was run out of Canada, where it was primary, but it involved actually 18 different countries, 82 different centers. Their goal was 7,500 patients, and as of August 2014, when they concluded, they had reached 7,507 patients, dating from anywhere from 2007 to last year. They had methylprednisolone, like I said, more of a North American study here, 500 milligrams versus placebo. They split the methylprednisolone dose, giving 250 milligrams at the induction of anesthesia, and then repeating another 250 milligrams at the initiation of a cardiopulmonary bypass. They had co-primary outcomes. So one of the primary outcomes they wanted to look at was 30-day all-cause mortality in patients with a high risk. So EUR score is greater than 6. And then their second primary outcome that they were going after was a composite of death, MI, stroke, renal failure, or respiratory failure within 30 days, similar to what the DEX trial was trying to do. And then as far as secondary outcomes, similar to all the parameters that we were looking at in previous studies, they were going to go after those as well and look for the same differences that we tried to look for earlier. In the end, as I said, 7,507 patients, almost equal number split between the steroid group and the placebo group. Each group had over 3,750 patients. These are all preliminary results, as I said. They have not been published. They've just kind of released some of it. Looking at their primary outcomes, their first primary outcome was just 30-day all-cause death. And they found that 4.1% in the steroid group, 4.7% in the placebo group, so really no difference in all-cause death between the two groups. And then their composite of death, MI, renal failure, stroke, and respiratory failure, again, no significant difference between the two groups. If you break it down and looking at individual components, this is something very, very different. No difference in stroke, renal failure, and respiratory failure, but something we hadn't seen in any of the previous trials. They found that the risk of MI, 13.3% versus 10.9% in the placebo group, led to a significant difference there. In patients who are getting steroids, we're getting increased risk of myocardial infarction postoperatively. A lot of secondary outcomes here. I'll just focus on the ones here that had some significance. Again, we mentioned the MI, higher risk of myocardial infarction postoperatively if you receive steroids. Similar to what we saw in earlier studies, the ICU length of stay was a little shorter, not that much here, but significant. And then also the sugar and the insulin that we expected. So higher glucose in the steroid group and a much higher insulin requirement in the steroid group as well. Interestingly here, atrial fibrillation, no difference, which is what the DEX trial had already shown us. Infection, the DEX trial had shown was lower in the steroid group here, no difference. Delirium, no difference. And surgical site infection, again, no difference at all. So now we're kind of left with some differences, even though we have these two large trials. Some of their early conclusions now, what they say is that methylprednisolone does not reduce death or major morbidity at 30 days for high-risk patients undergoing cardiac surgery with cardiopulmonary bypass. And it may actually increase your risk of postoperative myocardial infarction. Again, that was something that we hadn't seen in any of the previous trials. When the investigators were questioned on what do you think may cause this, one of the suggestions was that normally after surgery, the movement of glucose into the cells is needed for myocardial recovery, but these patients are all on high-dose insulin, and this insulin is leading to insulin resistance. And so now that insulin resistance is preventing the glucose from entering the myocyte for a recovery phase. And next line here, when same investigator who gave us this potential answer basically said, really, I have no answer. So we're waiting to see if they do some more analysis and try to figure that out. But there's no real explanation of why patients receiving steroids are having a higher post-op myocardial infarction rate compared to the control group. Overall, they conclude that steroids should not be administered prophylactically to high-risk patients undergoing cardiac surgery. So now back to the debate. We've got two large randomized trials to try to eliminate all those doubts from the studies from the 90s and the early 2000s, both very large, showing no difference in mortality, no mortality benefit when you include all of your patients, but they also have inconsistent benefits. So what we said, the difference in the infection rate, the incidence of delirium, one study showing improvement, the other showing no difference, and then also the Sears trial we said, showing actually potentially harm. So what does that leave us? Well, if you look at, again, back to the current use of steroids, there's significant variability in one practice from center to center. Some places use it in select cases versus all cases. My institution, we do not give steroids for every patient undergoing cardiac surgery, only select cases. If you look at my hospital right next door to us, the Children's Hospital, if you're a pediatric patient getting cardiac surgery, then you're getting steroids no matter what procedure you're getting done. So it just varies, like I said, from institution to institution. At Penn, we use it, and most of the centers will use it for any cases involving deep hypothermic circulatory arrest. So that would involve cessation of blood flow to the head for a short time, usually for aortic arch repair. And the thought there is that you're providing some form of neuroprotection while the patient's ischemic, although there's absolutely no clear evidence for that neuroprotection. This just kind of shows what we're talking about. So if a patient has an aortic arch aneurysm, the head vessels coming off of the aorta are going to have to be interrupted for a short time while they're sewing the graft in. And while that ischemic time is there, the thought is that steroids will prevent against any damage from ischemia. So this last slide, future studies, is another trial really warranted? We just had these two massive trials that kind of didn't really answer the question for us. Both of them kind of saying that you don't really need to give steroids in surgery, but one suggesting harm, the other suggesting that there may be at least some benefits and no significant harm. And we're still waiting for the final results of the Sears trial. They haven't actually published their paper yet. If we are to do any future studies, maybe we should do some head-to-head comparisons of methylprednisolone versus dexamethasone. Maybe there are differences that we're not seeing because of the choice of drug, and especially the dosing regimen. We saw there was significant variation in the dosing regimen from very, very high dose in the early studies to now low to moderate doses, and with the moderate doses even suggesting some benefit sometimes. And then we need to figure out if there's certain select subgroups, not just patients getting aortic surgery, that are going to be more benefit. Is it just the high-risk patients, the ones that have higher Euro scores or STS scores preoperatively, that may benefit more than others? And I think that's it. Sorry. Thank you.
So one question, I mean, and maybe my chemistry colleagues can help. Methylprednisolone is a lot different compound than dexamethasone as far as lipid solubility and ability to permeate this CNS. So can that have an impact on this?
Excuse me.
Yes.
I just had the same question as you, okay? Because you just try really commercially available steroids, I think. Some commercially available steroids. Okay. So did you think to use other type of steroids? I mean, which are yes, here,
Yeah, so very different compounds. But this is what's just commonly accepted. So for spinal cord injury, methylprednisolone has been very well established. So patients who have motor vehicle accident, concern for spinal cord injury, everybody gets put on very high dose methylprednisolone. The neuroprotection for the brain really hasn't been proven yet, but that's the drug that we have. And they're all going to be glucocorticoids, so I'm sure there's other options out there, but of the ones, like I said, North America seems to prefer methylprednisolone. Europe seems to favor dexamethasone. Not that we don't use dexamethasone, we use it obviously outside of cardiac surgery. There's a role. We focus today on just the cardiac surgery patients, but we use dexamethasone for preventing nausea. So no, besides these three, I haven't really seen any other drugs used.
That's because the difference is huge.
Yeah, and so why I mentioned that last slide, there should be some kind of head-to-head and not just convert everything to a hydrocortisone equivalent.
Right. I mean, I think the outcome, the differences in outcome could be explained by the chemistry.
So I have two questions. One, when you showed the data that indicated in the first study that there was a difference in delirium, that was all or none, either they had it or they didn't?
Yeah,
Is
so
there
that,
anything about
so,
duration?
No, there was not duration. Because the way our intensive care unit, I think a lot of them, they just go by these scales and say well, they meet this criteria different from their baseline, and that would suggest delirium. So I think there's varying scales, just like there's varying pain scales out there. I mean, delirium is somewhat subjective, and some could just say, well, if you're waking them up 6 hours after surgery, is this just a residual anesthetic effect? Because we see patients that just need a little longer time to get rid of their anesthetic, versus are they really delirious?
So is this the post-surgical psychosis? I mean, is that what is in that delirium category? And do these patients have that?
Have what?
The post-surgical psychosis, where they see things and
Hallucinations? Yeah, it can involve. It does include that. We'd have that sometimes, and we usually see it with giving these 80-year-olds a bunch of benzodiazepines, and then they are very delirious and take forever to wake up. as well, and when they do, it takes them really a while to become alert and oriented. So I think, like as I was saying, the different institutions kind of have their own criteria of what they said as, define as this patient has delirium versus not.
So also, do different institutions, do they do the same kind of anesthesia protocol?
No,
or
and one of the...
is that a factor of...
For delirium, certainly, that's going to be a confounding factor because, as we said, an 80-year-old getting cardiac surgery is going to require much less benzodiazepine intraoperatively and even postoperatively for sedation until they can be extubated off the ventilator. Our practice is to try to limit benzos in older patients, but younger patients, we want to make sure that they're not aware and they're going to receive much higher doses. So certainly a confounding factor that nobody really looks at. But as I said, delirium, this study, the goal wasn't really, that was more of a secondary outcome that they were looking for, not the primary.
First of all, it was a nice summary you gave. My question is, I think there must be some reason why physicians are going for the steroids. Why not use non-steroidal anti-inflammatory agents such as aspirin, ibuprofen, and naproxen instead of doing, because you use even concentration 250 milligrams. The same time you're given with the non-steroidal.
Yeah, I didn't mention that as an anti-inflammatory. We were saying the complement inhibitors and the A-protein, which we don't have, and steroids. But I mean, the great thing about the steroids is, as you guys know, pleiotropic. They have much more effect than just that one pathway to prevent inflammation versus like arachidonic acid pathway for aspirin. These are all cardiac surgery patients. A lot of them are going on aspirin postoperatively already, especially if they had bypass surgery. They're all going to be on aspirin post-op day 1. So in addition to that, going much higher, usually we don't because of bleeding. So even like if I want to give something like ketorolac, which is a stronger NSAID, for a patient getting non-cardiac surgery, usually it depends on what the surgery was. If there's any bleeding risk with the surgery, you'll find that many surgeons will want to avoid ketorolac, even though it's great for pain control too. But aspirin's not a big deal.
So how are the concentrations chosen for this type of, because how do you choose to give 250 milligrams prior and then after? How's that choice?
So that was one of the problems. I think, like I said, the earlier studies were all based on what was being effective for sepsis. And so they were doing very high doses. We'll just talk about methylprednisolone, very high doses of methylprednisolone to try to improve hemodynamics in a patient septic shock. And so that's what they had started using in cardiac surgery, and then realized that, well, as the years were going by and the studies kept coming, they started then changing the doses down. So you can see in the most recent Sears trial, we're only giving 500 milligrams, which is less than what I would give to somebody getting aortic surgery already. So I think that was just they're realizing, well, maybe you don't really need to go higher dose. So why 250 versus M250 again? I don't know, because some of the steroid studies, they just get one single shot and that's it. And here they're doing maybe just to see pulse, and see if it has any effect if you're giving it in double dose. So I guess try to get the serum concentration level up.
So I think we need to take a lunch break.